I've just started the recording of this open meeting in compliance with CMS guidelines. For the record, prior to doing so, I announced that Palmetto GBA would make an audio recording of the open meeting. Palmetto GBA only recognizes the Teams webinar recording that will be posted on the Palmetto GBA website as the accurate and reliable record of the meeting. I would like to just make a few opening comments, and then we'll let our two presenters go forward. First, let me just say that as far as the botulinum toxin dosing must be used in accordance with the US FDA approved labeling. This LCD addresses some off-label use, and evidence is reviewed and coverage decisions outlined. However, changes to the LCD must be supported by robust clinical evidence. For off-label botulinum toxin use not addressed, the provider must provide this robust published clinical evidence to support the dosing or serotype that's being used. For new approved indications for botulinum toxin serotype or dosing recommendations after the effective date of this policy, the qualified healthcare professional must provide the updated published FDA prescribing information to support the use of the botulinum toxin serotype or dose. The botulinum toxin administration must not be given more frequently than every 12 weeks, regardless of diagnosis, unless they're specifically addressed in the policy itself. The use of botulinum toxin for all cosmetic procedures is not a covered benefit under Medicare. The potency of each of the botulinum toxin serotypes are not interchangeable with other botulinum toxin serotypes, and therefore units of biological activity of any one serotype cannot be compared to or converted into units of any other botulinum toxin serotype. With that being said, I'm going to go ahead and allow the presenters to begin so we can go ahead and start with our first presentation. Dr. Mann, you are welcome to proceed.
Amandeep Mann, and I'm representing Ipsen Biopharmaceuticals for this presentation, for specifically in relation to Dysport, also known as abobotulinum neurotoxin. For the remainder of the presentation, I will be referring to this toxin as Abo or Abobon-A. Next slide, please. As a disclosure, I am a full-time employee of Ipsen and hold shares in Ipsen stock. Next slide. Disclaimer, this presentation was pulled together in response to the MAC request for feedback for the updated MAC draft LCD policy, consistent with the FDA-approved uses specifically for the Medicare population. Ipsen does not recommend the use of its products or any other products in any manner other than what is described in the FDA-approved prescribing information. Ipsen Biopharmaceuticals wants to recognize and thank the Palmetto GBA members for their efforts in updating this very comprehensive BONT LCD policy. I will take you through some key sections of the draft LCD policy that we feel clarifications or updates are needed to ensure that the policy is aligned with the FDA-approved labeling and published evidence, and hope that the policy can be updated to improve access for the care for the Medicare population to treatment of options like Dysport or abobotulinum neurotoxin. Ipsen will follow up with a detailed response letter, including all relevant supporting references and the FDA-approved label to be considered for the final LCD policy. Next slide, please. Abobon-A is approved for therapeutics by the FDA for the treatment of cervical dystonia in adults and the treatment of spasticity in patients 2 years of age and older. I'd refer you to the approved prescribing information for Dysport for complete details on the box warning for distance spread of toxins, contraindications, warnings, precautions, and adverse reactions. Next slide. Just a quick history, Abobon-A has been available in Europe since 1990 and was first approved in the US in 2009. It has been marketed globally for over 40 years with greater than 5 million treatment years of patient experience and over 1,300 peer-reviewed publications globally across multiple indications, including but not limited to cervical dystonia and spasticity. Next slide. The first request to the members are to correct the language for abobotulinum neurotoxin for initial dosing guidance for adult lower limb spasticity to align with the FDA-approved label dose. As indicated in the table on the right-hand side, the approved FDA BONT dosing recommendation for lower limb spasticity is up to 1,500 units. So just a correction in that dosing would be great. And this is in line with our registrational trial where we only showed that 1,500 units versus placebo was significantly effective in improving the spasticity in adult lower limb spasticity patients. The second request is to correct the language for Abbvie dosing in the subsequent dosing guidelines to what is indicated in the FDA approved label. Adult upper limb spasticity is 1,000 units max for upper limb. Lower limb spasticity treatment with Abbvie maximum dose is 1,500 units, and the total body dose should not exceed 1,500 units. So just correcting the language as per what is included in the label would be recommended for this segment of the policy. Request number 3 is to clarify the dosing limits prescribed in the subsequent dosing guidelines, specifically including the pediatric beneficiary details within that segment, and also correcting that the weight-based dosing should be 16 units per kg as described by the FDA label, specifically for pediatric upper limb spasticity. And the total body dose is 30 units per kg or 1,000 units for pediatric population. The fourth request is around clarifying the use of guidance or EMG and ultrasound relative to cervical dystonia. Previously, we have presented evidence that the use of guidance can improve. Guidance techniques may assist in mitigating adverse events and help visualize the target injection sites. And even in our FDA-approved label, we do indicate that the use of guidance technique is recommended as per the AbbVie prescribing information. Recently, we published a manuscript around that supported the use of guidance in a phase 4 study in adult lower limb spasticity that actually showed we had an improvement in patient goal attainment in patients that were injected with the use of guidance than those that were treated without using ultrasound guidance. So just an update in including guidance for cervical dystonia specifically would be great. And next slide, please. Thank you for the opportunity for being on the agenda and speaking on behalf of Ipsen. As mentioned, you will receive a written response with the feedback and on the corrections requested for Abbvie and the PI for you to review for the policy update. Thank you.
Thank you. If we can go ahead and have the next presenter.
Good afternoon, everyone. My name is Eric Busby. I'm Director, Medical Payer Strategy, and I represent AbbVie U.S. Medical Affairs. So on behalf of AbbVie, the manufacturer of Botulinum Toxin A, or Botox, and the patients that we serve, we would like to thank you guys for the diligent work that was done to develop this well thought out botulinum toxin injection policy and allowing us to comment on the reconsidered LCD. Additionally, all proposed language will be provided with the written comments. Next slide, please. I am a full-time employee and also a shareholder. So today I'll be focusing specifically on areas within the reconsidered policy that impact patient access and clinical decision-making for Botox across 3 key indications. That would be chronic migraine, cervical dystonia, and also overactive bladder. So our goal is to ensure the policy aligns with clinical evidence, guideline recommendations, and real-world practice while preserving appropriate provider flexibility and patient access. So the first key area that I want to address is chronic migraine. So overall here, we want to remove unnecessary step edits. So the draft policy requires 2 2-month trials across multiple oral classes prior to Botox. We respectfully request removal of this requirement and is not supported by current clinical guidelines. So per AHS consensus and global recommendation, CGRPs and Botox are both appropriate preventive option, not strictly step dependent. And so why did this matter? This requirement introduces delays in care, particularly for patients who cannot tolerate oral therapies, who have contraindications or have already failed prior therapies. And also an additional point here that I want to point out is that it also does not adequately account for combination therapy, which is increasingly used in clinical practice when monotherapy is sufficient. So we are recommending revision to adequately reflect combination use of Botox and CGRPs in chronic migraine. So ultimately, aligning with guidelines supports more timely and individualized patient care. So here, we're going to continue with chronic migraine. So the overall key message here is that we want to simplify and standardize outcomes. So the policy currently requires tracking both a 50% or more reduction in both headache days and also reduction in headache episodes. So we are recommending consolidating to a single clinically meaningful endpoint, which is aligned with our label of 50% or more reduction in monthly headache days. So this aligns again with our clinical trial endpoints and also real world clinical practice. So tracking multiple redundant measures creates administrative burden without added clinical benefit. And also on the disability measures, we support inclusion of functional outcomes, but recommend flexibility in the tools that are suggested rather than mandating specific thresholds. So this approach maintains rigor while improving provider usability. Next slide, please. The second key area that I want to address is cervical dystonia. So here we want to remove moderate to severe restriction plus allow clinical judgment. So the draft policy requires classification of cervical dystonia as being moderate to severe. We respectfully request removal of this language. Neither the FDA labeling nor AAN guidelines require severity stratification. We know that cervical dystonia is a heterogeneous condition and that patients with mild posturing, they may still experience significant pain and functional impairment. There's also equity concern that several thresholds may disproportionately limit access, especially for patients with limited specialist access and also underserved population. And on the objective measurements for cervical dystonia, again, we support objective assessment, but tools like the twisters, they're not designed for routine clinical use, and they do not reliably distinguish severity categories. So our recommendation here is allow diagnosis via clinical evaluation and differential diagnosis with flexibility and assessment tools. So the third key area that I want to mention is overactive bladder. So here we want to avoid restrictive dosing caps. So the draft policy specifies 100 units for initial dosing and subsequent dosing. And so we're requesting that the policy allow dosing up to 200 units, which is consistent with clinical evidence and guidelines. And so we will be providing you with the AUA guidelines to support dose escalation to 200 units in patients with inadequate response to 100 units. And also an NIH-funded trial called the Rosetta Study and other studies that demonstrate safety and efficacy at high doses. And so why does this matter? So if we're restricting patients to 100 units, this may result in suboptimal symptom control, and it limits physician ability to individualize treatment. And as you guys are aware that within our labeling for Botox, it allows up to 400 units in a 3-month period. And so this is not about exceeding label guidance. It is about ensuring the policy does not unintentionally function as a hard cap, limiting clinically appropriate care. So in summary, we respectfully, request 3 key considerations. Number 1, remove step therapy requirements in chronic migraine that are not guideline aligned. Number 2, simplify outcome measures to reduce burden while maintaining clinical validity. And the third is to preserve provider flexibility in both cervical dystonia, severity assessment, and also overactive bladder dosing. So these refinements will help ensure that the policy reflects current evidence and guidelines, supports individualized patient care, and avoids unintended barriers to access. So thank you guys again for your time and consideration, and I'll address any questions at this time.
I don't believe we have any other speakers, so if we have no further speakers, this will conclude our JJ open meeting. And thank you, everybody, for attending.